Good afternoon. It is May 13. Welcome to today's Samaritan's Purse International Health Forum. Thank you for joining us. We hope that you all participate in the conversation today, and you can chat with us in the chat box beside the video. Before we begin today, let's start with a word of prayer. Dear Lord, thank you for this opportunity to hear from Dr. Fisher. Grant us the wisdom to learn and apply these concepts to our practices. Lord, thank you for our health and strength in this time that we can spend together. In Jesus' heavenly name alone, amen. Well, we're excited to bring you a special guest today, Dr. Phil Fisher. He's going to present for us the top 10 papers on global child health. Dr. Fisher studied medicine at the University of California in Irvine, pediatrics at the University of Utah, and then went on to study tropical medicine at the Liverpool School of Tropical Medicine. He practiced and taught pediatrics in general pediatrics in Central Africa for 6 years, from 1985 to 1991, and is currently the professor of pediatrics at the Mayo Clinic. He's done research in nutritional deficiencies. He's the co-editor of the American Academy of Pediatrics textbook on global child health, and he now lives with his wife, Julie, in Minnesota. They have 5 grown children, and were recently blessed, I understand, Dr. Fisher, with a 3rd grandchild just this last Sunday on Mother's Day. Dr. Fisher, welcome.
God gives us the privilege of loving Him with our hearts, mind, soul, and strength. Today, we're going to focus our minds on how we can learn more to love better. We'll hopefully get inspired to have God's heart of compassion for others. And then hopefully we'll be able to use our strength to apply all of this in our current practice situations as God touches souls for eternity. Tom, thanks for the introduction. It is great having a 3rd grandchild born on Mother's Day. And thanks to each of you that's participating today as we consider the top 10 recent papers on global child health. One of my children last night was wondering how I had the authority to say what are the top 10 papers. And of course I don't, but they're just at the top of my stack of recent papers and chosen as the top because I think they might be relevant to you. As we see on the next slide, these are in fact only 10. They're not only the top, and in fact, there won't only be 10 because there'll be some 10 topics, but some additional papers with some of them. As a global-minded pediatrician, I find these papers to be useful, and they have new information that gives me good optimism as I look to the future. Hopefully, they'll also be useful papers for you as well, and maybe even a little inspiration as we all keep learning to serve people better around the world. Some of the findings we talk about are fresh and new, and they're not yet on label to be used. Some of them are off label, but you'll realize as we're talking about new research that not everything has been approved and is ready for application quite yet. Some of you have access to all of the papers that we mentioned. The slides will show enough reference details so you could find them. But if others of you would like to see the full details and have copies of papers, I'm just a personal email away at fisher.phil@mayo.edu. The first paper we're going to talk about, though, is more personal to us. What do we think? When I hear, if there is a physician on this flight, please identify yourself by pressing your call button. I must admit that I felt each of the things I put there, and I would expect that many of you have traveled enough to hear the flight attendants calling for help. What will we do when there's an emergency on an airplane? Will we feel like we might mess up, or we might save a life, or we just wanted to take a nap, or we might get a thank you gift out of the deal? Different things that we might think, but there are actually data, as we see on the next slide, that let us know what kinds of problems happen in different flights in different parts of the world. This paper shows a look at overall medical emergencies that took place in flight, published a little over a year ago in the Journal of the American Medical Association. And as I've experienced, and many of you have as well, the most common in-flight emergencies relate to fainting, GI distress, respiratory problems, and cardiovascular symptoms. People have heart attacks on planes, they can get into respiratory distress, they can have these sorts of things. That's prompted me when I hear the call for a physician to realize, oh, good, I know 3 cardiologists on this plane. They won't need me. But in that situation, it turned out it was a pediatric issue. The next slide pulls us into pediatrics a little bit more. As a study team looked at French airlines to find out what are the problems that are seen on French airlines for children and for adults. And this points out that sometimes we do have to be thinking about ourselves and what we as healthcare providers might be experiencing. They were finding that in-flight medical emergencies are increasingly common, and that pediatric in-flight emergencies are particularly stressful for physicians on planes. As a pediatrician, I'm more concerned that I might have to help take care of an adult with a heart problem, while most physicians are more concerned they might have to take care of a child. So they looked on French airlines and they realized that there were a few things that might help physician comfort, passenger comfort, when dealing with emergencies. So they thought that the emergency medical kit on airplanes should include materials to start intraosseous infusions and to give epinephrine via an automatic injector system. For those of us who already are pediatricians, we might find baby IVs and epinephrine dosing to be easier, even though that's stressful for adults. But I think these 2 papers actually point out to me that in daily life, we all have opportunities to help others. We can realize that emergencies happen and we can be ready for those, and systems are ready with material on airplanes so that we can provide emergency care as it's needed. As we see on the next slide, shifting to another paper, every decade or so, something big comes along. Certainly this year, we've all seen a big medical problem that's changed the whole world, but every once in a while, something really big and really important happens. That happened a couple of years ago in Africa with studies of azithromycin. We've realized in the recent years that azithromycin can save lives. They were doing studies in West Africa trying to prevent eye problems, trachoma, chlamydial infection that would cause blindness. And they found that not only was giving children routine doses of azithromycin cutting back the risk of blindness, but it was also saving lives. So there have been large studies involving thousands of patients getting 6 monthly doses of oral azithromycin. And they found out that there were 18% fewer deaths of children if the child happened to get azithromycin every 6 months. So this was not looking at neonatal deaths, but at those children that continued to live long enough for their every 6-month azithromycin dosing. There were about 1/5 fewer deaths from any cause because the children had received azithromycin. So recently, as the paper here in the New England Journal of Medicine shows, more recently we looked and seen what happens in the longer run. The initial studies looked at a year or 2 of treatment, and this study points out that even in the 3rd year of mass administration of azithromycin, the positive favorable effect was still continuing. Child mortality is reduced in communities when they get azithromycin every 6 months. Now we have to realize this does not say we should start putting azithromycin in the water everywhere or applying this in different settings, but in places in Africa where infectious illnesses are more common, it can be effective to think of population level treatment with azithromycin. The next slide is a little history of what I have learned in my 64 years of life, as I've seen society wondering, where does disease come from? When I was a kid growing up, people talked about nature and nurture. Was it our hereditary or our environment, our loving home situation that determined how we would be? As I went into my medical training, people were all excited about the Human Genome Project. And there were great ideas that nature, genetics, was the answer to everything. And we were conditioned by our genes. But then we found out that epigenetics matter. Different environmental influences, nurturing, can turn on and turn off different genes. So we were back to realizing that it's not just nature versus nurture, but it's nature, genetics, and nurture, epigenetics, that can make a difference. But now increasingly, in the last few years, we're realizing that it's not just the genes and the experiences, but it's also our interaction with other organisms, specifically the trillions of bacterial organisms living within each of us. We used to tease about royalty, talking about the royal we. If you were a king or a queen, you could say we, speaking for everybody else if it was your own opinion. But perhaps all of us should speak on behalf of my personal we, based on what I now know about my microbiome, the organisms living within me. The next slide has a complicated title from scientists in the journal called Science. And I had to even look up what one of those words means. A notobiotic animal is an animal raised so that you know every microorganism to which that animal is exposed in a lab situation with very few germs. But what these scientists did was to look at what difference would food make if we adjusted the food we fed animals and humans based on what those foods would do to the microbiome, to the intestinal flora, the organisms living within them. So the next slide gives a pictorial overview from this article. In the upper left, we see a reminder that as babies are born, they ingest organisms. And as they grow up, those organism patterns, the balance between different kinds of microorganisms, the patterns of the microbiome change through the neonatal weeks, through the infant months, and then on into childhood. Studiers, researchers have looked at children with malnutrition, and we realize that some patterns of the human microbiome, some patterns of the intestinal organisms in children are related to how well those children recover from having severe acute malnutrition. So some children start to get better with severe acute malnutrition treatment, and then their growth and recovery plateau and their recovery stalls. And they've realized, as people have studied this, investigators have realized that sometimes that limit to the ongoing recovery is because of the microbiome of the children, because of the intestinal flora that were not conducive to ongoing recovery from malnutrition. So in a series of clever experiments reported in the journal Science, they studied animals to find out how different foods would affect the microbiome. Then they studied human microbiomes in children with and without malnutrition. And then they devised malnutrition therapeutic foods with different features that would foster the growth of different intestinal flora. And in a preliminary study, adjusting the food we give to malnourished children based on the microbiome, the germs that would be in the intestines of those children, adjusting the food based on the microbiome would alter the recovery. So on the next slide, we see that people are now extending their results. They've got a protocol launched in South Asia where we're looking to see if we adjust our complementary foods for treating malnutrition, even in moderately malnourished children, how will this do? In fact, I think this is exciting. For me, trying to take care of malnourished children in different parts of the world, learning the World Health Organization's 10 steps provided an algorithm so that all children could get better care. So I could follow these 10 steps to provide care that would help children. Now, though, we're going beyond an algorithm to personalized, individualized medicine and adjusting some of the details of the ready-to-use therapeutic foods and complementary feedings to help treat malnutrition. This is not ready for prime time yet. We don't have the foods for each of the children we'll be seeing, but these are exciting developments that point to more help for more children as we continue the battle against malnutrition. The next slide points out something that we often hear or think. If a medication's available over the counter, it must be safe. Well, that thought has been rocked in the past year as we've seen studies of simple medicines that aren't so safe after all. So this one from the journal Pediatrics last year reminds us that using antacids in young children is not necessarily benign. Many of us got into an over habit, an excessive habit of giving acid suppressants to fussy babies, thinking that maybe some of their fussiness was from acid sliding back up into the esophagus. and that gastroesophageal reflux was causing heartburn, which was making children fussy. So many people were using simple antacids to try to help children be less fussy. Was that effective? That's debatable and it's not clear, but what we now know looking back is that there are also risks of this. So there are a lot of data on a lot of these slides that I'm showing, mostly that's so you can find the references or go back to them and study them more. But what they looked at was 850,000 children. These are large studies looking at databases of populations, this one in the United States, and looking to see what was the risk of having a broken bone in childhood related to the use of acid suppression treatment during infancy and young childhood. And it was found that there was a greater risk of fractures. Fractures occurred earlier and more frequently in children that had received proton pump inhibitors and H2 blockers, if they got them together. H2 blockers alone did not increase the risk of fracture, but using a proton pump inhibitor did. And if we added the H2 blocker, such as ranitidine, to the proton pump inhibitor, that further increased the use. So the reminder to us is to treat what needs to be treated, but to be careful about medicines that maybe aren't as safe as we might have earlier thought. So if we're going to start giving widespread acid suppression in infancy, we'll have to make sure that it's really necessary, because that is going to increase the risk and speed up the first incidence of fractures in children. Here's another study looking at the same kind of thing, this one with just 115,000 children, but looking at kids that did or didn't have fractures and looking at the risks of whether they'd had proton pump inhibitor use in the past. Again, a large pediatric cohort where proton pump inhibitor use was indeed associated with a real risk of fracture later on in life. 2 studies, same message. Proton pump inhibitor use is not completely safe for children. So as usual, we need to think before we prescribe. We need to make sure that the risks of the problem we're treating really outweigh the risks of what we're going to be causing by our treatment. But we shouldn't just glibly give antacids for young children, because there could be risks. As we move on, you might think this is the title of an old hymn, but in fact, there is power in the blood, even as there is power in transfusions for individuals that receive physical blood. There were a couple of papers in the New England Journal of Medicine that looked about details of transfusions for children in Africa. Those of us who have worked in Africa realize that severe anemia is a common problem. I was in one medical ward in Uganda once as I was walking around, and they said, yeah, we give at least 20 transfusions every night for severe anemia. That was a bigger place where I'd been than where I had been working, but still transfusions were a daily occurrence because of severe anemia. So the question is, how severe does anemia need to be to warrant giving a transfusion? Sometimes the anemia has come on gradually as people were iron deficient, as children weren't getting enough iron and weren't making new cells. And other times the anemia comes on quickly with severe hemolysis from something like malaria. And for many of my patients, and perhaps many of yours, the anemia can be of mixed causes, where a somewhat anemic iron deficient child then gets malaria and has hemolysis and gets lots more anemic. So the World Health Organization has given good guidance, good ideas about when we should transfuse children. And they made the point that if the anemia, even if severe, hemoglobins of 4 to 6 grams per deciliter, if the anemia is not complicated by signs of cardiovascular intolerance of the anemia, then perhaps anemia transfusions are not warranted. So for many of us working in a developed country, we would be horrified to see a child with a hemoglobin level of 5 or 6. Yet that's a common occurrence in Africa. Should we automatically transfuse or not? So there was concern by reasonable pediatricians that holding off on transfusion might be causing children to be more sick later on. So looking at the high mortality after severe anemia without transfusions and looking at readmission rates raised the question of, should we be less restrictive in the amount of blood that we're giving to children? Should we be more generous with transfusions for children with severe anemia, even if it wasn't complicated by cardiorespiratory distress? So in this study published 8 months ago, 1,500 children, roughly 2 years of age on average, were randomized either to get a transfusion right away on presentation when they had severe uncomplicated anemia, or to an observation group where they would watch and see how they did to see if they really needed to be transfused. The majority of these children, almost 2/3, had malaria. They probably had some iron deficiency in other situations as well. And then they followed these children for about 6 months to see how they did. They found that there was no difference in outcomes over those 6 months between those who right away got a transfusion and between those who didn't get a transfusion right away and only were transfused if they developed signs of distress with it. So that would support the World Health Organization idea. However, and even though that the decreased transfusion, the delay strategy, used less blood, however, there was a longer hospital to stay to have to watch the children, and more blood tests were needed at a greater cost. To me, that suggests that we're going to have to keep thinking. We're going to have to see on our setting where we are, what is the best and most cost-effective way to get a child back home and doing well in view of early versus non-early transfusion for severe anemia. So this validated what the World Health Organization suggested, with the caveat that it might depend a bit on the situation for the families we're treating. The next slide brings up another New England Journal paper looking at a different question for anemia. When children do have anemia and are going to get transfused, how much blood should we give them? So typically we'll give about 20 milliliters per kilogram of blood to take care of them, to bring them back up. That gets them out of the life-threatening danger zone. And then these children with treatment of the cause of anemia, iron deficiency, malaria, or whatever, can then gradually build their hemoglobin back up to a normal level. The question was, would it be better to give them a bigger transfusion, higher volume transfusion, instead of the typical 20 milliliters per kilogram? So again, out of over 1,000 children, people were either given 20 milliliters per kilogram or 30 milliliters per kilogram, and the outcomes didn't matter. So this, I think, is a useful negative study. It says that the 20 milliliters per kilogram is fine, and there's not necessarily a clinical benefit in more rapidly transfusing a larger volume and getting the hemoglobin level back up more quickly. History keeps moving on. I'm old enough to remember where I was when President John F. Kennedy was shot. Most of us can probably remember where we were when we heard the Twin Towers were falling on the original September 11th. And for some of us, the history that we remember where we were related to the publication of the Feast trial. I remember where I was and who I was with when I first read the Feast trial with its revolutionary ideas about resuscitating children. As we see in the next slide, we're reminded by recent studies that the Feast trial, that's the fluid expansion as supportive therapy trial. As I'm talking to you now, and some of you are going to be hearing this recorded message or series later, but as I'm talking now, our Muslim friends are feasting every evening after fasting all day during the season of Ramadan. That's not the feast we're talking about. We're talking about fluid expansion as supportive therapy. The original Feast study looked to see children hospitalized in 7 different centers in Africa with severe febrile illnesses that seemed like they were getting shocky. The question in the Feast trial was, should we bolus them with fluids, and what kind of fluids should we give? The shock of the original Feast trial was not just to patients in shock, it was to readers, to pediatricians, who learned that giving fluid boluses increased mortality. Most of us were trained thinking when the child's looking shocky with a severe febrile illness, we should rapidly restore blood volume with an intravenous fluid bolus to restore hemodynamic stability and circulation and help the child recover. We who believed that were wrong. The FEAST trial informed us that there is an increased mortality in providing rapid intravenous fluid resuscitation. So that's what we learned a few years ago, and I remember when I learned that. I remember telling a friend that was near me at the time who just discounted it because it was so revolutionary. But now we know that, but we still don't understand why. So this study cited here on the slide reminds us that people are still looking. Increasing bolus treatments, well, bolus treatments at all, the rapid expansion of fluid volume is associated with more mortality, but we don't know for sure why. So they looked at the timing of when children died, and it looks like the excess mortality was related to the first few days where mortality didn't keep dropping. So there's something about giving fluid boluses and the risk of that changes over time afterwards. There's something going on when we give fluid boluses that's disrupting the child's recovery from the illness in a negative way, and that's relevant days afterwards. This next study is another one looking at the explanations for the FEAST trial, and this is reanalyzing some of the initial data. The official background and conclusions are there, but in the middle of the short summary, where they had looked at normal saline versus albumin at different volumes in the FEAST trial. And people have debated this, as it says there. And as in the middle of the left of the screen, it says there has been no clear explanation why volume resuscitation was harmful. So we don't understand this. So what they did is they reanalyzed, they looked further at the old FEAST trial data to see why this would happen. And they found out that it was largely because volume resuscitation was associated with worsened breathing, respiratory function, and worsened neurologic function in some patients. More quickly giving fluids made it harder to breathe and harder for the brain to work. So now the question would be, can we restore circulation in a way that doesn't adversely affect respiratory status and central nervous system status? So more studies are needed. For me, I think we need to remember the FEAST trial says bolus intravenous resuscitation of fluids might be dangerous, but we need to keep thinking to figure out why so we can keep customizing what we do for patients. Now we shift gears. We're reminded at the time we're doing this seminar on this next slide, but we're reminded during these days of a terrible virus that pointed out that the world was not ready to deal with a bad virus. But it reminds me that we've had measles around for a long time, and measles continues to remind me that we, the collective, all of us, not just Royal, but all of us, we are failing. Measles is an infection that only relates to humans. There's not a hidden reservoir in animals. If we could stop measles in humans, there would be no more measles and it wouldn't keep coming back. And in the last 20 years, we've had repeated efforts with repeated gains to get rid of measles, but we haven't made it all the way. We keep having more measles. And it's not just us and them. It's not just rich or poor. It's not just North America or Europe or Africa or Asia, but we are failing in the fight against measles. So some recent papers, and here there are a few papers instead of just one. This one points out that we shouldn't point fingers at others. This is a look at the last couple decades of children dying of measles in the United States. There were over 1,000 measles hospitalizations during the 14 years of this study, as you see there. And it leaves kids in the hospital for a long time, and it costs a lot of money. And there were 34 kids that died. Measles is bad. And even in the United States, where we have ready access to a vaccine, there are enough people not getting vaccinated that measles is still a problem. The next slide reminds us that it's not just a problem in the United States, but it's a problem in Europe. People look to see where's there a problem in Europe, and they looked at parental attitudes and beliefs about vaccines, and they were able to identify specific population groups, cultural groups in Europe that chose not to access vaccines, as well as the risk, the same in Europe as in the United States, that many measles outbreaks relate to travel, where somebody comes in symptomatic or pre-symptomatic or recovering from measles, comes in from another country and brings another outbreak with them as they bring measles to share. So measles is a problem in the United States, measles is a problem in Europe, and how will it be in Asia? The next slide looks at antibody levels in Thailand and reminds us that their vaccination program is still sensible. Based on antibody levels against measles and other viruses, mumps and rubella, in Thai children, it still makes sense to continue with their current 9-month and 2.5-year 2-dose measles vaccines. We have different vaccine schedules in different parts of the world related to different epidemiology with different ways that people develop antibodies. But this is nice data from Thailand saying vaccination can still work, even there based on their antibody levels and the loss of maternal fetal protection by 9 months of age, that they can continue with the same problem. So the final of the 4 papers about measles on the next slide reminds us that measles eradication is possible, but it's not easy. And it's up to us as healthcare providers to decide what we're going to do about it. And as David Durkheim says, retreating is not an option. We need to keep pushing forward. We don't need a pandemic to remind us that we need to do more and we need to seek implementation of vaccine programs. We can look at history and measles and realize that we still have a lot we can be doing to help with vaccines. Unfortunately, not every disease is easily available or amenable to prevention by vaccines. The next slide reminds us that we have to be a little bit careful when we're implementing vaccines. Many were excited a few years ago when a new dengue vaccine held great promise, and then it was implemented and used in the Philippines before people realized that it was a dangerous vaccine and it was causing troubles. But science goes on and new vaccines are being developed. So even if we'll be cautious and make sure that we have adequate vaccine development before we implement widespread programs, we do need to keep pushing forward. So the Philippine tragedy is not the final word in the fight against dengue fever, but there's another vaccine that could be useful. So the next slide is another paper from the New England Journal of Medicine pointing out a new dengue vaccine with protective ability against all 4 of the serotypes of the dengue virus. And they looked at 20,000 children who either got vaccine or placebo, and then they compared to see how effective was this. And they looked at the efficacy, the protectiveness of the vaccine. The vaccine was safe and it was effective in preventing symptomatic dengue in places where the disease is endemic. So this vaccine is exciting. It means that we should not give up on developing vaccines against dengue. It means that there is hope that we can cut down on the terrible morbidity and mortality in children and adults from dengue. And we just need to keep moving. And we'll keep moving the slides because the next slide reminds us that times, they are a-changin'. And we've heard that from an old-time folk singer that grew up in Minnesota, but times are changing, and certainly our world has been rocked recently with the COVID-19 pandemic. So what's the issue with COVID-19 among children? Certainly, science is advancing hour by hour and day by day. But this study that was published online recently was a good look from China at what goes on amongst children with COVID-19. And there were several important findings of this study. First, children can be infected with the virus that causes COVID-19. Children are not immune to the virus. Secondly, it's equally seen in boys and girls. This came out at the same time in China. It seemed that men were having more trouble with the infection than women. And most importantly, COVID-19 does not seem to be as severe in children as in adults. So children can get infected, but they usually don't get as severely ill when they do get this new coronavirus infection. So I think that's important to us. It's a refreshing reminder that children are not going to be as much at risk of severe complications as older and medically compromised people will be. And that's why we've seen even in the United States in the past month that pediatric intensive care units were being co-opted by adults because there were so many sick adults with COVID-19 and there were not nearly as many children so sick in the hospital. And with decreases in elective care and elective surgery, hospitals weren't as busy. So it's encouraging to know that COVID-19 is not as severe in children as in adults. But that doesn't mean that it can't happen. In children as in adults, there is more risk if the individual is medically compromised. There have been studies looking at very young babies, newborns, and pregnant women, and it does not look that those are huge risks either, but medically compromising conditions are. Of course, in the last 10 days, and in the last couple of weeks since this paper came out, and then even in the last 10 days now, we're still learning more about what happens when this novel coronavirus infects children. And we're seeing some new things. Yes, children can get very severe disease. They can have a cytokine storm with a severe outpouring of chemicals that attack their body with a severe inflammatory response syndrome kind of a problem. Children can get rashes and they can get spots on their toes. Children can get sick with COVID-19, but even though they get infected similarly to adults, they tend to get less sick than adults. Even though they can get sick, there's less chance that children are going to get as sick as adults do. So science is still expanding. Within days, we'll know more, but we can continue the course as we as a society, we as the human population of the planet, continue to deal with the problem of COVID-19. Of course, dealing with widespread infections is not just a COVID-19 situation. I put a few statistics on the next slide to remind us of malaria. Most of us that care about global child health are involved in a program like this one today. Have been dealing with malaria around the world for a while. And we can compare. COVID-19 is tragic. Malaria is tragic. We're not trying to say one is better or worse or more worse than the other. But COVID-19 has been around, as far as we know, as a disease in humans for about 5 months. Malaria has been around for millennia, for thousands of years. Numbers are going up day by day, but we have about 4 million total cases of infection with SARS-CoV-2, the COVID-19 virus. We have about 4 million total infections thus far. Meanwhile, there are about 200 million cases of clinical malaria every year around the world. Statistically, malaria is still a big deal. We've had about 300,000 people on our planet known to die now from COVID-19. That is tragic and it's terrible, but we get about 500,000 who die of malaria every year. Mostly children and pregnant women, mostly in sub-Saharan Africa. But the malaria numbers are staggering all the time, even as COVID-19 numbers are rising in a very staggering way now. As we've mentioned, the WHO of COVID-19 is mostly adults for severe disease with risk of death. The WHO of malaria are these young children and pregnant women. And the where we already mentioned, everywhere for COVID-19, sadly and tragically, and mostly in Africa for malaria. We're eager for a vaccine to prevent COVID-19 so life can get back to normal. We've been eager for decades, for centuries really, but since vaccines were first discussed for decades, we've been eager for a vaccine against malaria. And malaria is not quite so conducive to a vaccine, even though progress continues. In the fight against malaria, there have been different things that have helped at different times. We've talked about DDT, we've talked about insecticides. That was helping a lot into the 60s and 70s until the mosquitoes became resistant to insecticides. We've talked about intermittent preventive therapy. And then in the fight against malaria, we found that insecticide-treated bed nets and residual household spraying with insecticides against the parasites, those were very effective measures. And the death rate and the case rate of malaria plummeted between the turn of the century and about 5 years ago. But then the improvements stagnated. So the next slide gives perhaps a glimmer of hope for what might be a novel and new way to help us fight against malaria. Microsporidians are tiny semi-fungus, semi-parasite organisms that very rarely cause human disease in immunocompromised people. But most of the microsporidians live in the environment and don't cause any trouble to humans. And some of these little fungal parasite strange organisms live inside mosquitoes. So in recent years, it's been determined that 9% of the mosquitoes carrying malaria, well, the Anopheles vector of malaria, 9% of them in parts of Kenya and Tanzania are carriers of a particular organism called Microsporidia MB. This is an agent that can live commensally inside the mosquito. In a sense, it's part of the mosquito's microbiome, and it doesn't seem to hurt the mosquito, and it might even help the mosquito develop its immunity. So why does this matter? This matters because mosquitoes infected with Microsporidia MB are unable to allow the development of malaria parasites in them. These mosquitoes can ingest malaria parasites with a blood meal from a human, but then those parasites don't progress through the abdomen of the mosquito, through the stomach, through the lining, and then back up to the salivary glands to be transmitted to another mosquito. A healthy, otherwise healthy Anopheles mosquito infected by this Microsporidian organism is unable to allow transmission of malaria. The Microsporidian organism blocks the development and transmission of malaria. This could be the wave of the future as a perhaps, hopefully, maybe final tool in our armamentarium against malaria. Yes, medication is great. Yes, some prophylactic medication is great. Yes, insecticide-treated bed nets are fantastic. Environmental control is vitally important. But now we have an organism that could be an agent of effective biological warfare. If further studies confirm these initial findings, it could well be that we can get all the Anopheles mosquitoes infected with this particular Microsporidian, and then all the Anopheles mosquitoes would be unable to transmit malaria to other human beings. Will this work? I don't know, but finally we found something that holds some hope. Previous efforts to have some sort of organism infect the mosquitoes killed off the mosquitoes, and so they didn't survive in the population and reproduce. This Microsporidian is transmitted from the healthy mother mosquito to its own baby mosquitoes to continue the blockade against malaria for mosquito generations to come. So we'll stay tuned, but this might be a potential new tool as we all head into the future. Well, there we've covered it, about 15 papers covering 10 topics that I think are important and useful as I share my interest in global child health with you. And I think that brings us to the end of this part of the talking time. And we have some time left to be able to interact, hear comments from you, and answer whatever questions you might have. Thanks very much.
Wow, thank you, Dr. Fisher. Just a reminder, if anyone has questions, to go ahead and post those in the chat box. A couple of interesting things I thought of, Dr. Fisher. Do they have any conceptual ideas of how they would administer the microsporidium MB? How would they transmit that to the population of Anopheles mosquitoes?
That's a great question, Tom, for an entomologist. It's already out there in about 9% of the mosquitoes of that species in some parts of East Africa. The mosquitoes transmit it to their children. I think the current thought is we will get a population of those mosquitoes, raise them in an artificial laboratory situation, and then be able to add them to the environment. So I think it would be getting infected mosquitoes raised and then dispersed by the thousands into the population, thinking that they would replace the native mosquito populations with these infected malaria blocking parasites. So it looks like it would not be trying to infect the local population of mosquitoes as much as it's introducing more and more infected mosquitoes into the population.
And then do they only see a lack of transmission of falciparum, no other forms of malaria?
So far, it's been falciparum that they studied because these studies were being done in East Africa, where about 98% of malaria is the falciparum form. And in fact, this study was of one Anopheles species, but it's expected that the same organisms would affect, the same microsporidian organisms would affect other Anopheles species. And it's expected that they would also be able to be effective against other types of malaria in other places as well. But we need more data to know that for sure. But it's mostly the falciparum, as you well know, that's the one that's killing most of the kids and the pregnant women.
Yes, that's great. Some comments are very appreciative of your talk, and I don't see any new questions, so I get to ask another one. Any thoughts? Is it an immune system difference in the children versus the adults in their response to COVID-19 infection? Is that what's causing some form of protection? It's maybe even the fact that we always comment that they have maybe a weaker immune system, a less mature. Is that in this particular case a good thing?
I like the question. I like the thought. I'm very hesitant to try to speculate anything. There's a lot of speculation about the whole COVID sort of a problem. I don't really know, but if we look at who has the biggest risk of COVID-19, it's the older than me people, the elderly that are older than me, or the people with other medical problems, not just immune compromising problems, but other medical issues. I'm guessing with you that the older age relates to some general weakening of the immune system, and the other medical problems just mean the patient doesn't have enough reserve to mobilize recovery when they're already compromised by something else. So I think it's that relationship to age and general health that would make children be less susceptible, as opposed to any specific immune difference. But more studies of serology are going to help us figure out all that immunity and everything else.
Great. Here's a question from Christy regarding the blood transfusion papers. Were they looking at whole blood transfusions or packed cells?
Those papers were, at least the 20 versus 30 was actually looking at whole blood. And I think that's what they were doing to be relevant. Many of the places where you, presumably Christy, and I work are places where we can't actually pack the cells. So we let it gravity pack as it's hanging there and dripping in. But in those studies, they were actually looking at whole blood transfusions when they calculated their 20 or 30 mils per kilogram.
Great. This is great. We have another question regarding azithromycin dosaging, the twice yearly. And did they suspect, or were there concerns or any studies regarding increasing antibiotic resistance in those populations?
As they have looked in those populations, they have not seen any antibiotic resistance developing. And certainly all this judicious stewardship of antibiotics is important. But not only did they not find resistance developing with the every 6-month dosing, but it was all-cause mortality that went down. The impact was big enough that it seems like it would even outweigh if there had been some little change in resistance. That was part of the reason why the study I mentioned looked at that third year, thinking that perhaps there would be more resistance, the azithromycin would be less effective in the population, and more people would be dying. So it's the right question, and it's the right reason to stay concerned and ask the question, but so far it does not look like that's enough of an issue to limit the use of the azithromycin.
Great. Okay, a question from Wesley. Can you comment on the measles epidemic in the DRC? 6,000 deaths and 90% children less than 5 years old.
I feel like crying when I comment about measles in the DRC. It was one of my introductions to life in Central Africa when I realized I had patients that were dying every day of measles during an outbreak. Most of the outbreaks in the DRC and elsewhere are simple reflections of immunity kids have gotten and vaccines. So you either get immunity from the vaccine or from the infection. And if you get the vaccine, then you're going to have immunity granted that way. In the old days, vaccine was just given once, and it was at a younger age, 6 to 9 months, when some children would have maternal antibodies still blocking it. So I think part of the trouble in the past in parts of Africa was a lot of the children still had enough maternal antibody protecting that their initial vaccine was ineffective. What we saw in the Thailand paper is the early vaccine should work based on the amount of antibody being given from mothers to babies in Thailand. So part of the issue was, I think we really need to make sure if there's a lot of measles around, we give 2 doses, the one early one, but then another to catch those whose maternal antibody blocked the effectiveness of it. But we also tend to see measles outbreaks coming in sub-Saharan Africa in about 3 to 7 year cycles. And I think that's just because enough people get sick and recover that then they're going to be immune, and we need that lack of herd immunity, and it takes a few years to get enough susceptible people than to have a lot of people that are infected. So it's tragic when it happens, but those that are already 5 to 10 years of age have either been vaccinated or had measles themselves if there weren't vaccines, so they're protected, and that's why it's the young ones that are dying. So it's a tragedy, and it's a tragedy that should be resolved by vaccination, but widespread vaccination means adequate healthcare systems and perseverance, and that's very difficult to do, especially in places, and parts of Africa are like this as well as parts of Asia, especially in places where there's not good trust of the medical system. That's been a problem for polio vaccine in Afghanistan, for measles vaccine in Congo in some places, and for Ebola outbreak control in some parts of Africa. So it's complicated. It's easy to say vaccinate everybody, but it's very hard to actually do that. And it's a tragic problem that's going on around the world still with measles.
Thank you. Dr. Fisher, I can't thank you enough for your time. We appreciate it greatly. And as I mentioned in my prayer, we sure hope that we can begin to make a change and apply these concepts as we go forward. Remember, there's CME credit available for this session. And yes, the talk will be available. The form and instructions for CME are in your email, and we'll be sending a follow-up email with the link to this recording. If you're not on our email list, you can join the forum at health.samaritanspurse.org. That's health.samaritanspurse.org, and be the first to know about upcoming events. Our next webinar will be Wednesday, June 17. So we look forward to seeing you all again, and thank you so much again, Dr. Fisher. Have a great day.
Thanks to all of you. Thank you very much, Tom, Dustin.
Oh, Mike, thank you.